Hey everybody, good evening and good morning for everyone. So, I just want to welcome everybody to another episode of the Rafael Medina subspecialty series. My name is Vini, and today we'll have a session focused on rheumatology. We have one special guest, Dr. Jeffrey Shen. He earned his medical degree and completed his residency training at the University of Alabama at Birmingham before pursuing a rheumatology fellowship at Duke University. He's now a first-year rheumatology attending at Duke University, where he leads the Duke Rheumatology Division's weekly challenging case conference. He's also engaged in research focused on improving diagnosis in care for patients with central nervous system manifestations of rheumatologic disease. So Dr. Shan presented a wonderful case on January 17th, and don't forget to check it on our YouTube channel. And we are really thankful to have you here as a discussant. So, Dr. Shen, I am curious to know what motivated you to pursue a career in rheumatology. And if you could share with us, what tips do you have to someone who is considering a career in rheumatology? Welcome.
Oh, thank you so much for that introduction. There's so many things, to talk about, but I think I'm going to focus, just because of, this podcast being clinical problem solvers on just how much clinical reasoning that there is that you can do as a rheumatologist. And I think that's actually one of the primary drivers that brought me into it. So when I was a medical student, the first patient I had actually was a person with autoimmune rheumatologic disease of the brain. And so that's why I kept since then on both my interests in rheumatology and some in neurology as well. I'll say that a lot of these patients, as you might have seen in some of your experiences, have really challenging presentations, and there's a lot of investigative work, and it requires a broad knowledge of internal medicine. And I think all these, things that drew us, when we were medical students into things like internal medicine or things involved with clinical reasoning are the same things that drew me into rheumatology. So if you really like doing things like clinical problem solving, thinking about challenging cases, rheumatology is an excellent field for that. I think one additional thing I'll say about it is that you develop a really long relationship with the patients over what is most of the time over their entire lifetime. And you get to see not only, how they were, how sick they were, sometimes even before you got to know them, getting to know them as much as you can, being part of solving what can be a complex mystery, and then seeing how well they can do afterwards. And that's truly one of the most blessed things that someone can truly experience. So thank you so much for having me here today.
Yeah, thank you. And outside of medicine, how do you like to spend your free time?
I'm an indoors person, so I really enjoy watching anime. I play video games. I hang out with my friends. I think those are the things that I like to do. One of the things that I've been doing recently is, kind of similar to my enthusiasm with problem solving. I've been reading through Agatha Christie books, and my mom's really enjoyed them when she was younger. So. We actually choose a book to read every couple of months, and we try to read it together and figure out what it is and discuss it.
So yeah, nice, wonderful. Besides that, I would like to introduce Mukun, who is a fourth year medical student from UCSF, applying to internal medicine. Before medical school, he spent several years in social work as a housing navigator and developing a street medicine program in Berkeley, California. And outside of medicine, he is a serial hobbyist and avid amateur astronomer. So I want to share that he's a valuable piece of our team, bringing fantastic cases and academy discussions. So Mukun, you told me that you're on vacation right now. So besides being a fantastic photographer, please share with us how are you enjoying your time these days. Not a specific vacation? Yeah, you're doing your elective. Can you share with us a little bit more of that?
Sure, yeah, thanks, Vinny. I'm doing a 1 month primary care and public health rotation in Costa Rica. I'm in a small city about an hour and a half outside the capital of San Jose, and I was a Spanish literature major in college. I love the language. I love the study of in Spanish literature in general. And so I thought it would be cool to, before I graduate in medical school, take the opportunity and do an international rotation. So I'm having a lot of fun. Today was my first day.
And so congratulations. And I'm sure that in the next few weeks, we'll have wonderful news for you. And the program you match will be very fortunate to have you. Yeah. So I also want to give a huge shout out for our academy members that are contributing for the session to being possible to made with. So, Himun, are you able to give us a hello and see how things are going?
Okay, I'm in the library. I'm sorry, I cannot say a lot, but I'm doing teaching point. And Dr. Shen, it's really good to see you again.
Yeah, thank you, Himun. And Amal is doing will do scribe for today. And Amal, can you share with us how's life?
Yes. So, hi, my name is Amal. Currently a third-year internal medicine resident going to infectious disease. I just matched a month ago, so I'm excited for that step.
Well, congratulations, Amal, and feel free to share with us the whiteboard, and we'll be able to start. Yeah, you can go ahead.
Sounds good, will do. Okay, so just to preface, this is actually a case that was seen by one of my good friends and CP Solvers team members, Maria Alemán. But we were talking about this case while we were hanging out a few weeks ago, and I knew this VMR was coming up, and it was just such a good case, I thought, to present with a lot of educational value. So I may not know all the minutia of the care since I wasn't the direct provider, but I've tried to put it together as best as I can for a rich discussion. So let's get started. The chief complaint is hospital transfer. And so I'll give you a little bit of an HPI here. So this is a 40-year-old woman with a history of scleroderma who presented with nausea, vomiting, and food intolerance to her primary care clinic and was sent to the emergency department after they found an anemia to 6.4 on a point of care hemoglobin test at that clinic. At the hospital, she was found to have a creatinine of 6.3, which is new for her, and she was admitted for workup of new renal failure with a biopsy done and the results pending. Renal replacement therapy was initiated at this admission, and she was discharged without further complication. However, 2 months ago, she comes back with acute respiratory failure. She's found to have Enterobacter pneumonia requiring intubation, with a course complicated by flash pulmonary edema ×2. She's now doing much better. She's been extubated, but they did an echo as part of this workup, and they found an ejection fraction of 20%. At this point, a transfer was requested as there was no rheumatology at this outside hospital. It was quite a rural one, and they wanted specialists to weigh in. So I know I've thrown a lot at you at this first aliquot. I think the discussion is probably going to happen more in the first part of this case than in the latter, but sorry, Jeff. Go for it. It's all you.
All right. Wow,
Yes.
that is a very, very rich aliquot of a very complicated patient. So, I'm gonna start beginning with just kind of telling you what my thought process is, just, first time processing it. And I think as a rheumatologist, especially on the inpatient side, the first thought is to quickly kind of just summarize the case in a way that'll let me know, is there a medical emergency that could be going on right now? Is there something that I should hold off on doing a little bit of broader, more detailed differential and do a kind of urgent differential first? And just very quickly, just hearing the word scleroderma, the first thing that I think of already is there's a condition called scleroderma renal crisis. And it's an emergent condition that people with scleroderma can get that needs, very urgent attention and treatment. And so that's the first thing that I think of before even like kind of thinking about more about the differential that I want to make sure is always going to be on the table on the differential diagnosis, whether or not there's something in addition that could be going on with it. Um, so that's just my first thought, hearing that word and then listening to some of the symptoms. We're having a lot of GI symptoms. We're having this anemia of 6.4. So my mind is already going to, is this related or not related to this diagnosis that I'm already concerned of about scleroderma renal crisis? Um, so a little bit more about scleroderma and renal crisis. So scleroderma, it's a complicated autoimmune disease. One way to think of it is it kind of has these three different pathophysiology branches. One is an autoimmune branch where it causes a lot of inflammation. One is a sclerotic branch that causes usually a lot of skin thickening, but also thickening in other areas of the body. And then this other branch called the vascular branch where it affects well, for lack of a better term, vasculature, and it causes something called the TMA or thrombotic microangiopathy. So immediately, because I'm hearing, scleroderma, I'm thinking about renal crisis. I'm looking at the anemia that's at 6.4. I'm wondering, could this patient have a hemolytic anemia, specifically a thrombotic microangiopathy? So we're already kind of going into like really detailed diagnoses, but the reason I hone on these diagnoses immediately first is because, we need to consider them right away first before considering other things in the differential. So that's my first thought for the initial things that we see in the very beginning of this very rich aliquot, and then the next thing is going to 2 months later, having this pneumonia and flash pulmonary edema, and looks like they're very, very sick right now. And when a patient's really this sick, it's very important to try to get as much information as you can before making any big changes and thinking about what are the most urgent problems, prioritizing the differential based off of that. So now I'm already thinking, it sounds like they could have had some type of microangiopathic hemolytic anemia, probably scleroderma renal crisis. And now it sounds like maybe they're having a pneumonia on top of that. And the last part of this aliquot, which I'm not 100% sure how to put together, is this new finding of heart failure, that's severely reduced ejection fraction. Most of the time, I'll say when I see this in a rheumatology patient that's sick, it's a stress cardiomyopathy, right? So that's the first thing I'm thinking, but I always want to make sure, I'm not, closing on that diagnosis. Those are my initial thoughts.
So yeah, what a wonderful initial thoughts. And I want to came up with some questions about your comments, Dr. Shen, if you excuse me. So what kind of tests or clinical findings would help to differentiate between the, as you said, the subtypes of scleroderma and also scleroderma renal crisis? If you would proceed for, like, if you go in your thought process for normotensive scleroderma renal crisis, or even the TMA subtype, or another cause of renal failure in this patient. So just to summarize, what will help you to differentiate and will guide you through the next steps?
Yeah, that's an excellent question. So yeah, if I was initially there with that patient when they first came in, so with scleroderma renal crisis, there are a couple of things that we look for. It is a TMA, so a thrombotic microangiopathy. So what you would see is evidence of hemolysis, evidence of schistocytes on the peripheral blood smear. For hemolysis, the other ways to find that out are labs. So we'd be looking at haptoglobin, LDH, indirect bilirubin, things like that to help support that diagnosis. The other part of it, of the TMA that it causes is it causes renal dysfunction. And usually the AKI can be pretty rapid and pretty severe. And the urinalysis that we would typically see on that would have, it could have a lot of white blood cells. It could have pyuria, it could have hematuria and proteinuria. But and oftentimes actually is completely bland, and that doesn't rule out scleroderma renal crisis. The other part of it is that typically patients do present with a really high blood pressure that is in the 200s. And because of that, sometimes, when you're not familiar with scleroderma renal crisis, or even if you are, you don't realize that they present for other causes or other consequences of hypertension. So, for example, you can present with flash pulmonary edema from hypertensive crisis just from the blood pressure side, or I've seen it cause seizures due to press. Right. And sometimes that confuses the picture a little bit because you're not putting those two things together. But that's also one thing to keep in mind. And typically how we manage it when we get people with really high blood pressure, interestingly, is we start them on short-acting ACE inhibitors, and that actually stabilizes the renal function. So that's another piece of evidence that we can sometimes use to say, okay, things are going in the right direction.
All right. Well, amazing. Some little bit of questions more, and regards to the stress scleroderma related cardiomyopathy that you mentioned. How do you think about that, and how if that will change the prognosis in the patient, and what are the implications for managing the patient's heart failure in this condition with severe reduced ejection fraction?
Yeah, I think that can be very challenging. Honestly, in the beginning, you want to stabilize the patient. You want to protect whatever renal function you can. You want to bring the blood pressure as close to normal as you can without hopefully causing hyperperfusion. And we do that really quickly, often. As far as, kind of longer term management afterwards, like what do you do in the setting of the heart failure, setting of stress cardiomyopathy? I think we do rely a lot on our cardiology colleagues to help us determine, is this going to be a setting in which we may see it recover because it's just stress cardiomyopathy, and we just need follow up with some preventative medications, or do we need to do anything particularly before they leave? I think from a rheumatology standpoint, the most important thing is to have the ACE inhibitor as part of the blood pressure control regimen because it has the most evidence for managing this disease. But talking about this disease in this setting, we are a little bit honing on to that this is the correct diagnosis. So I think before I want to go on and say doing all these things for scleroderma renal crisis, at this point, I still am not 100% sure that we are dealing with scleroderma renal crisis. And I want to broaden the differential up a little bit. It sounds like it could just be a TMA, right? We have to confirm also that the diagnosis of scleroderma is actually true, or it was accurate actually. So that's how I'm thinking about it in the beginning.
Yeah, perfect. And one more question. Do you think that do you know the literature and the studies, the papers that reveal a poor prognosis for a patient with considering stress cardiomyopathy related to scleroderma, or do you think that the prognosis will be worse in case of other manifestations of the disease?
That's a good question. So I'll be honest, I don't know if particularly with stress cardiomyopathy, the relationship between that and scleroderma prognosis. If I had to guess, I would say it would increase or it would be a poor prognostic factor. Just having renal crisis itself and having renal dysfunction from scleroderma is already a really big poor prognostic factor. So that is essentially the biggest thing I'm worried about. And the way I'm thinking about it, at least right now, is not that the scleroderma is causing directly causing a stress cardiomyopathy, but maybe the sclerodermal renal crisis, that the vasculature nature of that pathophysiology, I guess, of the sclerodermal renal crisis, that is causing the stress cardiomyopathy. So I wonder if we can just control that, can we improve the stress cardiomyopathy, and can this patient bounce back? That's what I'm focusing on.
Yeah, perfect. And what further, like the patient also had some pneumonia and pulmonary complications, and do you want to consider some further workup that would you recommend to evaluate pulmonary complications at this point?
That's a good question. I think the first thing is I want to confirm that this is a team. So I like to do things step by step. And when I get a patient on the inpatient side with a complex history, right, I very frequently assume all problems to be from different issues, then unifying them together. And I see more and more often that patients with autoimmune disease present to the hospital actually have two or more, three things happening at the same time than just the one. So I investigate the different things by themselves. So, the nausea, vomiting, food intolerance, is that related to a GI manifestation of scleroderma? Is that completely different? Is that, for example, viral gastroenteritis? The anemia, like making sure that this is indeed from hemolysis and it's not from bleeding, because you can also get bleeding. Many patients with scleroderma have vascular ectasias or something called GAVE, which are these small malformed blood vessels that lead to easy and difficult to control bleeding in their gastrointestinal tract. So right now, before, honing in and saying, I'm sure this diagnosis, investigating things step by step, what's the anemia from? What's the nausea vomiting from? What's the AKI from? And then if they all kind of turn towards the same area, then I think we have a clearer picture and can be more certain that this all fits. And I think we have a renal biopsy and, we don't have the results of that yet, but that is one of the big pieces of the puzzle that will help us.
Yeah, totally. So yeah, first things first, we're trying to broad our differential diagnosis and see a big picture. Yeah. So yeah, you can please you can say the second aliquot for us, please.
Yeah, that sounds good. Yeah, I think this is a tough case to discuss, right? Because and I appreciate, Dr. Shen, your insistence on questioning the information that you've been given, because I think in many cases you get hospital transfers that a lot of workup has been done, and you are you're carried away by the diagnostic momentum of what's been done already. And I think you'll see in this case that it's very wise of you to reconsider some of the information that you've been given. So we'll move on to the next aliquot. So past medical history is scleroderma, was diagnosed in 2003, so over 20 years ago. And the presenting symptom was a skin thickening on the hands. She says that she took some pills that may be methotrexate that softened that skin, but she hasn't taken pills for many, many years. She developed Raynaud's about 1 year after her diagnosis, but she doesn't remember any other symptoms of scleroderma having affected her. She doesn't remember who she was seeing. As far as a review of systems, she denies dyspnea, no cough, no myalgias, no reflux, no digestive issues aside from this incident that sent her to the hospital 2 months ago. No joint pain or swelling, no rashes, no oral ulcers, no photosensitivity. The only med that she remembers being prescribed that she still takes is losartan. Family history is non-contributory. Social history, she is a strawberry picker in a farm in Central California, and she's been doing that work for many years. She has 3 children, and she lives with them and her husband. She doesn't drink, she doesn't smoke, she doesn't do any drugs. She has no allergies. That's your second alcohol.
Yeah, so Dr. Shen, I am curious to know what thoughts are crossing your mind regards to the long history of scleroderma and also Raynaud's, and maybe if you can comment about the behavioral history and health-related behaviors would have some issue or indicate or point toward something that could help, or it's just noise in the case.
Yeah, this is getting more interesting. I can't help but to think about, what does strawberry picking have to, is there association that I'm missing with that? So that's where my mind is right now. But going to the scleroderma, it is a little bit unusual that, if you've had scleroderma and it's been untreated for a really long time, and maybe it was a little bit mild at first, it's what it sounded like, only on some pills for a couple of years. Um, does it really mean that she has a diagnosis, or maybe this is something completely different? Now, unfortunately, because if you think about emergent diagnoses, scleroderma renal crisis is still on top of the list. We still have to assume that maybe it is true. And I actually have seen personally a few cases of scleroderma diagnosed at 20 years ago, and exactly like this has not done anything. Patients on no medications, and then 20 years later develop scleroderma renal crisis, bringing them into the hospital. So it's definitely still a concern. I would say the major thing that you need to make sure a scleroderma patient has, if you're asking, questioning the diagnosis, is do they have Raynaud's? Because a large majority, about maybe like 99% of patients with scleroderma have Raynaud's, and often with the Raynaud's, it's severe enough that you can see changes on what's called a nail fold capillaroscopy. So Raynaud's is when you have spasms of the small, tiny capillaries that go to the end of your digits or other extremities. And people with scleroderma have such severe vascular disease, that it affects the Raynaud's essentially is almost constantly active, and you see permanent changes to the capillaries there, which can be identified on a nail fold capillaroscopy. So that's one thing, that could be interesting to do on exam. Another thing is to know, have they had complications from Raynaud's? Because you can get cyanosis of digits, you can get ulcers, which are quite common with scleroderma. It is true that, if you had skin thickening, for example, from scleroderma a long time ago, it may get looser over a long period of time. It goes in phases where it first becomes edematous and thick. And then initially after that happens, it becomes just mostly thick and fibrosed. And then after a while, it kind of gets a little bit looser again. But still, you're able to see or feel changes on physical exam even over a long time. So I'd be paying attention on physical exam for those signs of scleroderma. Looking at the other things, she's already on losartan. I don't have anything that I can think of an association with this picture. It looks like there's no family history of it, which, we often try to use family history to see, if somebody had an autoimmune family history, maybe they're more likely to have it. But not having a family history doesn't help me necessarily in saying that they don't have a disease like scleroderma. And then, now we're on to the kind of the social history where, she's from California and she's a strawberry picker. There may be some association to a disease that I can't think of right now there. So I'm just going to keep that on the back of my mind. But I can't really make much of that as a clue at this point. And then we see, that she's, really importantly, not a smoker, not a drinker, doesn't do other drugs. The important thing to think about with all autoimmune diseases, including scleroderma, is that sometimes they can be mimicked by drug or medication use. And there are certain ones that can produce a very similar autoimmune phenotype. And that usually is lupus, or something called drug-induced lupus. And very rarely would it be something like drug-induced scleroderma. However, over reports over a long time with skin thickening, there have been rare case reports of things, for example, like tryptophan causing a very similar condition that can cause some skin thickening. So I always keep that in the back of my mind. But right now, I think still my leading favorable diagnosis is either scleroderma or some type of TMA.
Yeah, perfect. Just one question before we continue with the physical exam. From your experience, and do you know about how long could be the window between like the diagnosis and the manifestations of scleroderma?
Yeah, I will say it's just general. Like generally, it's within a couple of years, but I have seen cases where it has been very similar to this. Patient got diagnosed when they're 18, now they're 36, 38, and they've had scleroderma for maybe 20 years, on no treatment because it's been mild, and suddenly they've developed renal crisis. So I don't think that there's a time point for when they could develop it.
Right, perfect. Well, thank you so much. It's been a wonderful discussion so far. And please, Mikun, bring to us the physical exam.
Yeah, sounds good. So we'll start with the vitals. Temperature of 98 Fahrenheit, afebrile. Blood pressure of 87/58. Heart rate of 80. Respiratory rate of 16. and sitting at 100% on room air. And keep in mind that at this point in the transfer, her respiratory function has greatly improved. In general, she looks severely cachectic and exhausted. The head, ears, nose, and throat exam reveals thin skin around the mouth, but without any lymphadenopathy in the cervical chain, without any salivary gland hypertrophy. Mucous membranes are moist, and there's no evidence of oral ulcers. As far as the cardiovascular exam, it has regular rate and rhythm with no murmurs, and her lungs are cleared auscultation to the bases on both sides. As far as the musculoskeletal exam, there's some thickening of the skin distal to the PIP joint on both hands, with some hyperpigmentation, some hypopigmented macules, and prominent fingernail clubbing. There's no evidence of joint warmth or effusion in any joint. And proximal muscle strength was also tested in the upper and lower extremities and was found to be intact, 5 out of 5. So that's the relevant physical exam. The next will be some labs and some more interesting findings.
And do you think that's a good place to stop, Mikun?
Yeah, I think we can talk about this briefly and then move on to the next.
All right, good.
Okay. Yeah, so just briefly, I'm noticing a couple things. One, the blood pressure standing out. It's, not as I expected in someone with renal crisis. Usually it's hypertensive. And I'm not sure if this is, after they've been treated for a long time with their, blood pressure medications or where we are here, but it is still unusual for me to see a blood pressure that low with it. So that's one interesting thing that I'm noticing. You can have scleroderma renal crisis that is normotensive, but I've never seen it be that low with it. So that's an interesting thought to give a little bit more pause on saying that this is definitely scleroderma. The other thing that I'm noticing is that, the thickening is distal to the, okay, I think I said distal to the DIP. So, the thickening in scleroderma, it's, if it's distal to the DIP, for example, it can be hard to notice. Distal to PIP is fair because that's when you first can start to see some thickening. But it's important to be able to differentiate the two because some people just normally have thicker or skin that's distal to the DIP joint. And the way that you measure skin thickening, on an exam is you try to pinch the skin with your thumb and index finger and see how much you can pinch. And you can even try it on your, skin that's distal to the DIP, and you'll notice that it's fairly impossible to do that. So it's very hard to examine skin thickening from there. And then if you try, with your, so, the DIP joint being here, if you try to pull it, you can't, but you can at the PIP, like over the PIP joint, pull it with just your finger, your index finger and your thumb, and you're able to like take that off. And so you can use that as a measure. So it seems like that she maybe does actually have some real sclerodactyly. Fingernail clubbing is interesting. I don't really typically associate that with scleroderma. Although, I do associate it with pulmonary manifestations, and you can get it as an end result of a long history of pulmonary hypertension. So if they indeed did have scleroderma, I would be wondering, do they have, ILD or pulmonary hypertension? And is that causing the fingernail clubbing? On the other hand, what if this is not scleroderma, right? And so the things I think about with fingernail clubbing are, often lung malignancies and other types of malignancies. And those can sometimes cause DIC, which is a microangiopathic hemolytic anemia, and that can sometimes mimic scleroderma. And so I think that's another thought to be asking at this point is we have some evidence of scleroderma here, but we also have evidence of other things that may not be expected with it. And so we still need to keep a broad differential at this point. And then based off of new things that come in, new information, I think we use that to clarify the differential. And at this point, I don't want to go into too much of like too broad, I guess, of a differential, because I don't think we have enough clues for us to really go to one direction or another. I tend to rely on ideas or clues as they come by and use that to direct where I'm going to go in the differential. So I still think at this point we're at that state where we're talking about emergencies. It's still TMA or scleroderma renal crisis. And then from a non-emergency differential diagnosis perspective, it's okay, we have things that are looking like scleroderma, but I'm still needing to really confirm each piece of the puzzle.
Yeah, perfect. So we're trying to differentiate between the primary etiology and mimickers, basically. And but besides that, I think, do you think that we can use the same thought regards to the pulmonary manifestations, if that like the pulmonary edema and being a consequence of the scleroderma versus the pneumonia secondary to Enterobacter leaving a scar tissue and manifesting a I don't know, some kind of pulmonary disease afterwards?
Oh, that's an interesting question. Usually when I see fingernail clubbing, I'm thinking of a chronic manifestation. I'm not sure if it can change acutely. So that's why I don't tend to think of it as like a result from Enterobacter pneumonia. So my first thought is that it's more likely to be related to a chronic disease. And if she does have scleroderma, then that would be the first thought. And if she doesn't have scleroderma, then the first thing that I'm worrying about is lung cancer. It's interesting that the lungs are clear to auscultation, and sometimes it can be hard to pick up on the crackles. But oftentimes with ILD, if you have that with scleroderma, you can hear crackles, fine crackles throughout the entire lung area. So interesting she doesn't have that, but I think we still have to keep our minds open at this point.
Yeah, totally. Well, that's very clarifying. And yeah, you can feel free to announce the other aliquot.
Good. Yeah, we'll do. This is great. All of the discussion points that I was hoping we'd touch on are here. So this is fantastic. I'll give you some labs. White blood cell count of 7.5, hemoglobin of 9.8, platelets of 390, hematocrit of 30, an MCV of 90, an RDW of 16.3, which is a little high, and a ferritin of 1200. For basic chemistries, sodium of 137, potassium of 4.7, chloride of 96, bicarb of 23, creatinine of 5.6, BUN of 44, calcium of 9.7, phosphorus of 6.5, which is high, magnesium of 2.5, which is normal, and glucose of 75. She got dialysis the day before these were drawn. And a repeat echo, which I'll give you now, shows moderate eccentric left ventricular hypertrophy with an ejection fraction of 55 to 60%. There's also evidence of a bicuspid aortic valve, and the pulmonary artery systolic pressure and right atrial pressures are both within normal limits. So that's this aliquot. There's going to be one with all the room labs and one with some biopsy information just for time budgeting purposes.
All right. Well, thank you, Dr. Shanna. What is crossing in your mind now?
Thank you so much for that. So I think there's a couple things that we're seeing here with the objective data that is still consistent with a possible diagnosis of scleroderma. Looking at, we have anemia. We still don't know yet technically if it's hemolytic or not, so that's still going to be one of our next questions. People will often talk about platelets when you're considering hemolytic anemia or when you're considering a TMA. Because oftentimes when you have a severe TMA, and this is actually specifically TTP though, you will have a fall in platelets. So I have been asked a couple times, do we think that the normal platelets makes it less likely for this to be TMA or scleroderma renal crisis? But I think honestly, the answer to that is that it doesn't really give us a hint one way or another, and we can't use the platelets here to rule out any types of TMA, except maybe it makes TTP less likely since that's a more prominent feature of TTP. And then looking at the other things in the labs, we know her creatinine's still really high, and that could also still be consistent with, what was originally acute renal failure from a scleroderma renal crisis. From the echo, and I'm not sure if this is before or after when she had the EF that dropped to 20%. But at
This
least
is
from
after.
there,
This is more. This is like
oh, this is after
right
now.
during this hospital. This is a repeat one. Yeah.
Got it, got it. So the EF coming back to 55, 60 really brings me back to this possibility of a stress cardiomyopathy, maybe acutely lowering the ejection fraction to 20%. We see that in a couple situations. Number one, when you have really bad autoimmune disease, a severe flare, which you could see, for example, in scleroderma renal crisis. And another times it's just sepsis. You know, it could be completely unrelated to the underlying autoimmune issue and just having sepsis and stress cardiomyopathy from that. And we know that, you know, that patient did have Enterobacter pneumonia and was severe enough to have renal failure needing intubation. So that could have, you know, maybe made the patient sick enough to have an EF drop down to 20%. The bicuspid aortic valve, not really sure what to make of that in this scenario. I think, you know, if we wanted to keep our differential broad, we could think about things like aortic stenosis, which sometimes is difficult to tell on an echo. And then sometimes people with bicuspid aortic valves can have aortitis. But I don't see in this scenario that we need to kind of go down those thought processes. So I'm going to hold off that for now and say that maybe it's not as relevant to this specific scenario. But yeah.
Yeah, perfect. So one quick question: the fact that the patient is normotensive and is not on presumably a clinical picture of hemolytic anemia or thrombocytopenia, does that interfere with your reasoning or considering differential diagnosis?
Yeah, that's a good question. I mean, I would say that these things were done after, so it's hard for me to tell right now. I mean, you could certainly have had scleroderma renal crisis before, and maybe it's not active right now. You can also just have scleroderma and have just kind of this low-level hemolysis, which, well, we don't really have any words for. You know, as with a lot of other things that we do in medicine, we like to put names to things, but the names only make sense in black-white scenarios, and in reality, a lot of things are gray. So, you know, we don't usually call something like 15% scleroderma renal crisis, but theoretically speaking, you know, as people get worse or people improve, they will kind of get better or worse gradually. And sometimes if you're not getting labs that often, or well, previously when you don't get labs that often, it will seem more black and white because you'll have this clear scenario of worse, and now you have all the pathology in the labs, and then once they're better and you check them, they're all better. But now, because we have access to more labs, access to more investigations, more and more we're seeing all these cases where we're in between. So is it possible, for example, that this patient is recovering from a renal crisis? They have been maybe adequately treated, or maybe that's stabilized now. And now we're dealing with issues that are from a different source, for example, related to infection or something completely different even. You know, the fact that they are low in blood pressure makes me think that it's less likely for them to still have renal crisis going on. Um, and also that they're on a medication, an ARB, which in theory is helping with scleroderma renal crisis. Although we tend to use ACE inhibitors more, there is some evidence that an ARB can help in cases where patients, for example, have angioedema to an ACE inhibitor. We go with an ARB in those cases. So right now, although I'm still keeping my eyes open, I'm thinking that, you know, right now it may not be renal crisis that we're dealing with, and let's figure out, you know, what's causing this new presentation.
Yeah, so I'll need to rewatch and recap every every teaching point that you're making. So thank you for that. And Mikun, yeah, go ahead, please.
Yeah, that sounds good. This aliquot, I think, will give you a lot of the info that you want. But it's cool to hear you talk about the cardiovascular manifestations more too, you know, because I think this was a big tension point during the case itself, that before the repeat echo was done, there was a thought that this could actually be a scleroderma manifesting in the heart. And, you know, there was some discussion that scleroderma could, you know, the TMA of scleroderma could involve the microcapillaries of the myocardium, could be causing some kind of cardiomyopathy in that regard. I think fortunately for the patient, she recovered her ejection fraction without any specific intervention. But let's move on to this next aliquot, where you'll get a CK, which was 14, which is low. troponin, which is normal, a haptoglobin of 255, which is high, and LDH, which was normal. Now to the room labs. And ANA was sent and came back with a titer of 1 to 80 with a diffuse pattern. The P ANCA came back at greater than 1 to 600. C ANCA was negative. The anti-centromere was negative. The anti-RNA polymerase 3 antibody was at 55 with the normal upper limit of 20. The anti-SCL70 antibody or topoisomerase antibody was negative. Anti-dsDNA, Smith, and RNP were also sent and came back all negative. And for complements, C3 was normal and C4 was at 47.7 with an upper limit of normal being 30. So this is this aliquot. There's one more small one, which is just the renal pathology, and that'll be the end of the case.
Yeah, thank you, McKeon. And Dr. Shanna, I want you to share with us what you're thinking now.
Wow. I mean, a lot of unexpected things. First of all, questioning the diagnosis of scleroderma, but then also this P ANCA being really elevated and how to interpret that. So, so a lot of things. So the first thing is, whenever I look at autoantibodies, I always tell myself or try to remember that, the patient and their clinical manifestations is still the one that's telling the story, and the antibodies are only just there to guide us. So you can easily end up in situations, for example, that if you are only looking at the antibodies, or if you're putting the antibodies at priority, you can get distracted as to what the real diagnosis is. Some cases, for example, like patient has tuberculosis, but you're stuck in your mind thinking that that patient has a positive ANA, and you've thought they had lupus and they look like they have manifestations of lupus, but this whole time it was tuberculosis, right? So um, I always take it with a grain of salt. I think there are a couple of things that are notable here. One is, you have an anti-RNA Pol3 that's elevated. Okay, that's consistent with scleroderma. But we already knew that that was high on the differential, so then that's okay. I don't think too much more on that. You can go through like manifestations of different autoantibodies and talk about things that we teach on boards or test on boards, like you'll have a higher likelihood of scleroderma renal crisis with RNA Pol3. Honestly, I will say that these kind of differences in probabilities are very difficult for the human brain to comprehend, both as a physician and especially as a patient. The possibility of scleroderma renal crisis to me is always there as long as you could have scleroderma. So while, it's nice to have an antibody that kind of points us like, okay, we need to be worried about it more, I tend to just focus on the fact that things are possible and I need to be there and ready to catch them. So, while the RNA Pol3 is elevated, I'm more interested still in what's going on with the P ANCA. So my first thought is, with the P ANCA that's positive is this ANCA vasculitis? And that would be a very, very interesting question because, well, it's not something that we really discussed at all during this whole entire time. It's not something that I was really thinking about. So that's the first thought. But the other thoughts that I have is that, ANCA can be false positive in rare scenarios. And in those scenarios can make things very, very complicated. Because in those scenarios, the things that mimic it are infections and malignancies. And if you treat it at like ANCA vasculitis, you could be doing the patient harm. So what are the most common, mimickers of ANCA vasculitis that will cause a positive ANCA? Number one, if you're talking about a single infection, it's mycobacterial. It's TB worldwide. Honestly, I don't tend to see TB that much. Maybe I'm lucky because our ID colleagues do such a great job of diagnosing TB. Oftentimes when I see positive ANCA and it's false positive, it's from a fungal infection. Aspergillosis is the most common one I've seen multiple times with a positive ANCA. So that's one thought that I have. The second thought is just an overall, any cause of endocarditis, bacterial endocarditis, it could be strep, it could be staph, can cause a positive ANCA. And I'm not completely sure why that's the case, but that's the other thing to think about because there's many manifestations of endocarditis that mimic ANCA vasculitis. The kind of, the fancy one that you really like to talk about to sound smart is Bartonella specifically, or maybe Coxiella. And those specific organisms can cause a positive ANCA, make it look like a ANCA vasculitis. So yeah, that's like always in the back of my mind. But that's what I'm thinking so far. Okay, where is this ANCA going? Do I need to evaluate this patient for an infection, for vasculitis? So then we kind of rethink the scenario. Okay, so what are the manifestations in this patient that would be, for example, consistent with ANCA vasculitis? Um, well, first thing is they did have renal failure. They're anemic. They have this quote unquote flash pulmonary edema. Could it be that this flash pulmonary edema and drop in hemoglobin is nothing to do with scleroderma or the pneumonia? Maybe it's diffuse alveolar hemorrhage from ANCA vasculitis. And so that's one of the first thoughts is that, we need to make sure that that's not what's going on in this case, because that is also a life-threatening emergency, and it's treated differently than scleroderma renal crisis. The second thing is, with an ANCA vasculitis flare, so you have the pulmonary side, where it can cause, at the worst, diffuse alveolar hemorrhage, but then you also have the renal side, where it can cause glomerulonephritis, which is usually rapidly progressive. And, maybe we thought this whole time it was scleroderma renal crisis, but maybe instead they actually just had ANCA vasculitis. And so, what will help us determine that is usually you start off with urinalysis, urine protein creatinine ratio. And then if you see that there's proteinuria and you see that there's red cell casts, then you have a lot of suggestion that this is possibly ANCA vasculitis, and you can get a renal biopsy to confirm that. There are several benefits of investigating through a renal biopsy here because you have two different diagnoses: one, renal crisis, and number two, ANCA vasculitis, that are both severe life-threatening emergencies treated differently, that you can actually differentiate on the renal biopsy. Because scleroderma renal crisis often doesn't occur with a glomerulonephritis, and ANCA vasculitis doesn't cause TMA. So it would be very interesting to see if it could differentiate the two. And honestly, it might show both, or it might show a third pathology. And I've seen cases where you've been in the situation where it shows three different pathologies. You see a TMA, you see glomerulonephritis, and then you see something that maybe looks like lupus. And then you get a little bit confused. But knowing the different types of pathology from a rheumatologist perspective helps determine which medications I can use safely and which ones are more likely to be effective. So those are like the initial thoughts of, how do you think through the ANCA vasculitis part? Now let's talk about a little bit about what if this is not ANCA vasculitis, but a false positive ANCA, like I said before. So we can consider, endocarditis. Okay, we have an echo. It looks like there's no vegetation in the echo. If we really wanted to push it and we were really worried, since they had recently had Enterobacter pneumonia, do we need a TEE to make sure there's no vegetation from Enterobacter there? I think that is one potential thought. The other thing is repeating blood cultures, which is much easier, and making sure that at least we're evaluating for that possibility. Um, Again, if we're talking about atypical infections, Bartonella is usually the one that we think about, but any atypical infection causing an endovascular infection can cause a positive ANCA. I go back to thinking about the social history. They're from California. It doesn't really tell me much in terms of, like Bartonella or something like that. I don't really associate strawberry pickers with a lot of things. Maybe, for example, if I really wanted to stretch it out, they were strawberry picking, there was a thorn, and then they got, a fungal infection, sporotrichosis from that. So we can really examine them again, make sure that there was no puncture site. And usually those infections, will be local and you'll have lymphadenopathy that travels up the site of where the puncture was, right? So there's kind of some stretches to think about there. And lastly, I didn't discuss this, but, there are medications that can cause positive ANCA and cause drug-induced ANCA vasculitis. I am not aware if losartan can cause that. That is something to look into. But one thing I think we think about commonly that causes that is hydralazine. So I'd look back, they were maybe hypertensive initially at some point, and did they get hydralazine? Is that something to think about? Do they have hydralazine-induced ANCA vasculitis in a patient that also has scleroderma? So lots of things to think about and investigate, but I think the renal biopsy is going to show us a lot.
Perfect.
Your audio is cutting out.
Oh, sorry. Yeah, that was most of my investigation.
Yeah, maybe I can just ask really briefly, what you think about the haptoglobin and the LDH.
Yeah, so the haptoglobin and LDH, haptoglobin is high, LDH is normal, so no evidence of hemolysis right now. What that points to is that at least right now, what the patient is probably not undergoing scleroderma renal crisis or a TMA. Because if you were undergoing a TMA or a renal crisis, you would show signs of hemolysis. You would show schistocytes, usually on peripheral blood smear. So we know right now, at least, there's probably no signs of a scleroderma renal crisis. However, I'm not too sure that means maybe 2 months ago when they first came in, it was definitely not scleroderma renal crisis. So that's why I definitely think a biopsy is still important to do.
Excellent.
Yeah, perfect. I think that it's a good time to turn off the renal biopsy. You can.
Yeah, let's do it. This is the last one. So the renal biopsy showed 90% global sclerosis of glomeruli with significant interstitial inflammation comprised predominantly of lymphocytes and occasional eosinophils. Notably, there was no evidence of GN. There was no evidence of either intra or extraglomerular capillary thrombosis.
Yeah, Dr. Shen, do you have any thoughts regarding the biopsy, please?
Well, that's interesting, and it's a little bit surprising. So we're not really seeing what we typically would with ANCA vasculitis or with scleroderma or even with lupus. Um, it looks like to me this is showing some interstitial nephritis, and it's confusing as to what that could be caused by. There are a lot of autoimmune diseases that can cause it, but I wonder if those are related. So typically, from an autoimmune perspective, if I see interstitial nephritis, I think about sarcoidosis, but this patient doesn't really have any manifestations that will make me think that diagnosis makes any sense. The other times that you can see interstitial nephritis is I've seen it with lupus before. It is a really rare manifestation when you see it with lupus. Um, and it's possible that, if you think through other manifestations again, to reconsider, could this patient just have lupus and scleroderma renal crisis? But I don't think we have enough evidence to point for that. So I would be a little bit hesitant to go down that thought pathway. We have interstitial inflammation, which, from a non-rheumatologic cause has also other possibilities. But what I typically think about is something drug-induced. Could it be a medication-induced interstitial nephritis? And lastly, could this be something like lymphoma, which sometimes can present with interstitial nephritis and have a lot of positive antibodies that don't really make any sense? It would be interesting to see, if there's any lymphadenopathy that the patient has, if there's any other thing that's making us think that this is a malignancy that's causing it.
Yeah, so Mukin, we are curious about how was the approach of the medical team regards the findings in the biopsy and how that could relate with the scleroderma versus CKD of the patient, and yeah, what do you learn from that, and what you could share with us?
Yeah, sounds good. So, this is going to be one of those unsatisfying ones where the final diagnosis is actually still quite unclear. She was discharged without an official diagnosis. Sorry, Jeff. Yeah, I know you got the case with no diagnosis. But I thought it was such a good one to share because I think at every step there's a pretty big twist in the findings, and it looks rheumatologic all the way through, and it still could be quite rheumatologic at the end. But the big debate that was happening before this patient was discharged was between rheum and nephrology, and because so much of the information from this case, including the renal biopsy and the path read, were obtained from the outside hospital, right? Biopsy was called as 90% interstitial fibrosis and tubular atrophy, or IFTA, which is a pattern that can be seen after long-standing scleroderma renal crisis, but is also something that can be seen in a broad variety of other causes of CKD, including the much hotly debated hypertensive nephropathy. And Notably, this patient did have a long-standing history of hypertension, including severe hypertension at the point of her prior hospital admission, although throughout the admission that she was at UCSF, she was not hypertensive whatsoever. The debate on whether this was scleroderma renal crisis at all was also an active one. There are some clear hallmark signs of this potentially being a renal crisis, but the pathology findings don't really support it. The time course may not necessarily support it. And we don't see any active evidence of a TMA, of course, although historically there may have been one. There was an interesting article that I read about some of these new classifications of scleroderma renal crisis into this narrowly defined subtype versus a TMA subtype, with the TMA subtype being, of course, one with classic findings of maybe thrombocytopenia, low haptoglobin, high LDH, histiocytes, so on and so forth. But with this narrowly defined one presenting almost exclusively as just hypertension, and which responds better to ACE inhibitors, whereas it seems like there may be some role for pheresis or even for eculizumab, indicating some complement-mediated mechanism in the TMA-mediated subtype of scleroderma renal crisis. So be curious to know your thoughts on this. But at the end, I think she was discharged in reasonable condition. She's not healthy, of course, but she was stable and so was sent home. She's going to continue her dialysis. She's going to have rheumatology follow-up in the outpatient setting, and her losartan was changed to an ACE inhibitor, which she's tolerating well. But I think this was just such a cool case for me to learn about and read through, in part because of so many false positives along the diagnostic journey from the echo that initially suggested potential cardiac involvement of scleroderma. And, that was actually the reason she was transferred, is that they were so worried about cardiac scleroderma that they wanted the patient to be in a facility with a rheumatologist. To this potentially false positive p-ANCA, to hints of potential TMA at the beginning that didn't end up panning out in the labs. And, I thought it was just a cool case, and it was really wonderful to hear your discussion, Dr. Shen.
Yeah, and Dr. Shana, besides the comments from you, I would also like to inquire you about a possibility that Mark announced it in the chat. Maybe that could be a manifestations of an overlap syndrome between scleroderma and ANCA-associated vasculitis, or that wouldn't be feasible with this clinical picture. What do you think about that?
Wow. Well, yeah, very, very interesting case. But yeah, fascinated to see what will eventually happen to this patient. I do think that, it is something to consider, that could they have both scleroderma and ANCA-vasculitis? Is it just that because we have a combination of these two different diseases, it makes the picture difficult to understand? So I think it, will require a lot of thought from the rheumatology perspective, a lot of investigation, but also a lot of just monitoring, what are the things that are getting better, what is getting worse with the different treatments. And this is a tough patient to really consider that in, because, on the one hand, you have scleroderma and maybe you want to avoid steroids, as sometimes that can precipitate renal crisis. And then on the other hand, to really immunosuppress somebody, or to have ANCA-vasculitis, you really do need to immunosuppress somebody. So, and steroids are a very big part of that. So it's a very fascinating case. With this renal biopsy and the kind of the undiagnosed ending, I think at this point, I agree that the best that you can do is monitor and make sure that you understand as things go by, to just be clear on what is active and what's not active. Bill St. Clair, who's was the chief at our department at Duke, he told me a really great piece of advice is that sometimes with rheumatology, you don't figure it out the first time that you see them. And sometimes it just takes following them for multiple visits over a year or even longer. And then the picture basically becomes clear itself. And the first time you see them, you just have a lot of different pieces and not enough to make sense of it. So it would be interesting to see what happens. I think it's going to be important to keep a broad differential, especially with, so many unanswered questions. But yeah, overall, really fascinating case. I mean, I learned a lot of things too. I wasn't that aware of For example, this possible microthrombosis of a cardiac scleroderma renal crisis. So that's interesting to think about and consider. But yeah, overall, thank you so much for this case, Okun.
Yeah, we are thankful to have you, as I said before. And just to end the session, we would really appreciate if you could bring to us just a couple of teaching points, brief teaching points that you learned from the case.
Yeah. So I guess right away, the first teaching point is that, a lot of times when you get these patients, they're very complicated and you may not get a diagnosis. And so the first most important thing is don't hone in just to the diagnosis that you're being told, especially in rheumatology. You want to investigate it, confirm it. But the second part of that is while you're questioning it, you still, interestingly, have to have the ability to assume that maybe it is true and manage it as if it were true. So I kind of run two differential diagnosis lists essentially at the same time. One, the differential diagnosis list for emergent things that I have to be aware of. Usually that's like sepsis, pulmonary embolism, and then a life-threatening rheumatologic manifestation. And in this case, it could be scleroderma renal crisis or ANCA vasculitis flare. And then behind that or underneath, I have a separate differential of what is the kind of overlying diagnosis. And I think the important part is that while you may not always get a diagnosis from the first, or in this case, actually, even both categories, the second, the underlying autoimmune diagnosis, that often you will just have to take a longer time, and you sometimes have to just be okay with not knowing the diagnosis at the end of the inpatient hospitalization, as long as you've covered and managed the first part well and gotten stability in terms of all the emergent causes. So I think that's an important thing because a lot of times as clinical problem solvers, when we discuss through cases and, in morning reports, we focus a lot on, just a differential diagnosis and thinking through each different scenario. But I think it can also be helpful to have two lists, one to help you respond right away and one to have in the back of your mind while you're still investigating. So those are just some pieces of advice that have helped me.
Yeah, well, thank you so much for joining us and being in the discussion today. So thank you, everybody, and thank you, Mukun. See you in the next session. Bye.